we're going to get started. Today, we'd like to welcome Dr. Adil Husain. I'm going to read this. Dr. Husain is the division head of the Pediatric Cardiothoracic Surgery program and surgeon-in-chief of the Pediatric Children's Services here. He obtained his medical degree in North Dakota and his general surgery residency at the University of Iowa. Did his fellowship in Pediatric Cardiothoracic Surgery in North Carolina, correct? No. If it's important, he'll tell you about it. He joined the faculty here in 2008. Prior to that, he was at the University of Florida. Because this is a pediatric talk, we have the little pediatric baby here. We're going to put here so he feels comfortable here. And today he's going to talk to us about the evolution of congenital heart surgery, why every beat matters. Again, some will ask, why do we have these non-transplant talks? And because I'm the director of transplant grand rounds and I get sick and tired of transplant talks, I like to have these multidisciplinary talks. So that's just to give you a perspective on my part.
Sure. Well, thanks for having me here today. I'm not usually much of a microphone stand at one spot kind of guy, but we'll do that. It's a pleasure to come here. I asked Greg, why do you want me to come talk to you guys? Same question, and he gave me the same answer. But you know, in thinking about the talk, one of the things I hope to share with you today is some of the things that we've done over my time here and historically with our program that I think likely mimics a lot of the things that you all do. Really one of the most important aspects of how we deliver care to our patients and the patient population we're responsible for is through a large multidisciplinary approach. And it requires a lot more than just the surgical aspects of what care these children receive. And so throughout the hour, you may, I hope, feel like there's some similar themes in terms of structural things you all work to strive towards every day and challenges you all face in terms of how you interact and how you make sure all the pieces of your care team puzzle fit so that it suits what the patient and the family needs. And so hopefully some of those themes will resonate with you. So we'll talk a little bit about advances in congenital heart surgery. I didn't want to just focus on how we structure our team and things we're doing in regards to our team. I thought I'd give you a little background on really one simple statement, which I'm sure I'm biased, but it's truly amazing to me how much congenital heart surgery has advanced even in 2 to 3 decades of time. There are several lesions that we surgically now treat that back in the 70s, 80s, and even into the 90s were thought to be non-treatable lesions, or in a vast majority of instances, when neonates unfortunately were diagnosed with these lesions, they were given palliative care. And so there's a lot of reasons for those advancements, and we'll go through Hypoplastic Left Heart Syndrome and Transposition of the great vessels just as two sentinel kind of lesions that have seen a significant evolution in terms of how we care for them. I wanted to also spend a little bit of time telling you about how disparate the treatment and care of congenital heart disease is around the world and why it's a valuable and important thing to recognize that in what we're doing not only locally in our program, but also somewhat internationally to try to narrow some of that disparity. And then tell you a little bit about our program here, and clearly, as many of you know, we moved to UHS about 1.5 years ago, and to just very openly and transparently with you share some of the challenges we faced and some of the structural things that we've evolved into since our time here. So over the past 4 decades, the changes in surgical options for congenital heart disease aren't just because the surgeons have gotten better or because we're technically more gifted. It's really because of a lot of things that happen in and outside of the OR prior to the operative intervention and then in our post-op care. Echocardiography, catheterization tools and techniques, cardiac CT and MRI, all of these things have gone really leaps and bounds in terms of better delineating for us, not only structurally, but in a 3D fashion, and then even more importantly, sometimes physiologically, what types of lesions we're dealing with even prior to the operating room setting. And it gives us really an excellent roadmap in terms of strategizing what operative intervention to pursue and how to pursue that when we actually get to the OR. What we do in terms of putting kids on the bypass circuit also has changed dramatically in the last several decades. We've come to understand and recognize that the smaller circuits are very valuable in terms of minimizing post-operative inflammatory responses. And so the miniaturization of the circuits, what the circuits are constructed of in terms of the tubing, using things such as heparin-coated circuits to try to minimize some of the coagulopathies and other types of challenges we face in terms of removing a baby's entire blood volume, pumping it through a machine and getting it back in the baby. And then things like modified ultrafiltration, which essentially are components of our bypass machine that act essentially as a kidney throughout the entire case, ultrafiltrating the child. All of these things haven't, again, done anything in terms of helping us to technically be better. But what they've done is they've allowed for some of the insults that we have to place upon these children while we're doing their repairs to be less destructive in terms of an immune response, an inflammatory response, and overall the ability to allow these kids to heal and get better quicker. So hypoplastic left heart syndrome is a lesion that oftentimes is thought of as the most challenging lesion that congenital heart surgeons deal with. And I think there is some truth to that. It's really a group of malformations marked by hypoplasia or non-development of left-sided heart structures. So that's going to include intracardiac-wise, the mitral valve and the left ventricle, and then the aortic valve and extracardiac, the ascending aorta and the aortic arch. And so to simplify this lesion, it's essentially a lesion that renders a child with a single pumping ventricle. And it's important to note, and you'll see this at the end of this slide, that this is just one form of single ventricle anatomy or single ventricle physiology. There is also lesions that are related to hypoplastic right heart syndrome, meaning they have tricuspid atresia, a small right ventricle, pulmonary atresia, and a small pulmonary artery. And so the thing to realize for both of these types of scenarios in terms of single ventricle disease is that they're born and their ductus is essential for them to maintain survival, whether it be the ductus providing blood flow to their pulmonary arteries or the ductus providing pulmonary or blood flow to their systemic perfusion. In terms of hypoplastic left heart syndrome, it's obviously the inability to provide adequate systemic perfusion. It's about 7% of all infants with congenital heart disease, and its incidence is about 0.16 per 1,000 live births. So here's a pictorial that shows hypoplastic left heart syndrome. That's not what I wanted to do. Thought maybe this would have a pointer, but it's okay.
It does.
It does?
Yeah, the middle button.
All right, perfect. So here's your hypoplastic left ventricle or non-existent left ventricle. Your mitral valve is here. Here's your right ventricle and your main pulmonary artery, and the ductus essentially emanating from the main pulmonary artery is attached to this hypoplastic arch that then goes down to a descending aorta. And so the systemic perfusion is dependent upon ductal flow. There's very little, if any, antegrade flow throughout that ascending aorta. So it's a hypoplastic aorta, hypoplastic left ventricle, and ductal-dependent systemic blood flow. The status of the atrial septum, or the wall between the left atrium and the right atrium, is also critical, because if that septum is restricted, then all of this blood flow that's going out to the lungs in terms of pulmonary venous return has nowhere to go. And so one of the first things that we need to recognize in kids born with hypoplastic left heart syndrome is to see if they have an adequate ASD or an atrial level communication. And if they don't, they need an emergent intervention to give them that opening so that all of the pulmonary venous return has somewhere to go. So this is Bill Norwood, and he is the father figure of the Norwood procedure, which some of you may or may not have heard of. And the Norwood procedure is the first operation that kids with hypoplastic left heart syndrome undergo in a series of palliative operations that they have over the course of their first 2 or 3 years of life. As you can see, the operation was described, not in terms of performed or results, but described in 1983, so not that long ago. And what this operation entails is to use the pulmonary artery, so this is the right ventricle, the pulmonary artery, and make that the systemic outflow tract. So you combine that with the diminutive ascending aorta, and you have one large outflow tract. Oftentimes you have to use patch material to create this new neo-aortic arch. And so the first process is to create a systemic outflow tract. The second component is if you're going to steal the main pulmonary artery away from the child to create the systemic outflow tract, you have to create a new way to get pulmonary blood flow. And so that should be in some form of a shunt, and this is number 2. This is a BT shunt, a Blalock-Taussig shunt. Another shunt that we're using much more frequently now is actually a shunt that goes directly from the right ventricle to the pulmonary arteries, and that's called a sono shunt, and I'll show you a little bit in terms of the outcomes that have been provided for using the sono shunt. And then also to ensure if that atrial septum needs to be opened even wider, that it is, because if we're dealing now with a functional single ventricle, we essentially need to have a functional single atrium, so a single collection chamber. And these are the steps of a Norwood procedure. So Norwood first described his results with this operation in 1991, again, really not that long ago. And it was 151 patients who had hypoplastic left heart syndrome that they decided to treat with a surgical approach and not through palliative care, through a 3-stage surgical approach. So the stages for single ventricle physiology, the stage 1 is a Norwood, the stage 2 is a hemi-Fontan, and the stage 3 is a completion Fontan. And without getting into the specific anatomic details of the 3 operations, I wanted to show you just what his first series of outcomes were for the 150 or so patients that went through these operations. So only 78 of the 151 survived through stage 2, so there was a 50% mortality. And only 28 of the 151 got through all 3 stages, so a 72% mortality. So only about half the kids got through the first operation and made it to the second operation, and less than a fourth of the kids made it through all 3 operations. Now, if you look at the current data, and this actually is aged somewhat as well, but if you look at data right now through several programs out there in terms of what their stage 1 mortality rates are, they're somewhere in the high single digits to the teens. And so that mortality level that was 49% in 1991 by the guy who actually described the operation has now fallen. And most programs report a stage 1 mortality of somewhere between 10 to 15%. And so we've seen a lot of improvements, in that short time span from 1991 to current day in terms of what that mortality figure is. And overall, if you look at our program here at the Health Sciences Center over the last 5 years, we've had a mortality rate of 12% for stage 1. And we've actually had a survival rate of about 78% for kids getting through all 3 stages. So it's really amazing to see how a lot of these advances that we talked about earlier have actually shown us result differences with hypoplastic left heart syndrome. So transposition of the great arteries. Transposition of the great arteries are when the 2 large arteries that are leaving the heart, the pulmonary artery and the aorta, are actually hooked to the wrong ventricle. So the left ventricle is receiving oxygen-saturated pulmonary venous flow from the left atrium. And this oxygen-enriched blood should go out the aorta to the rest of the body, but instead in these children it goes to the pulmonary arteries, which then goes to the lungs, back to the left atrium, back to the ventricle. And so this is one circuit that isn't actually connected to the systemic circulation. On the other hand, the desaturated venous return comes to the right atrium, goes to the right ventricle, and instead of going out to the lungs to get oxygenated, goes out to the systemic circulation, comes back into the venous return to the heart, and so it's another circuit. And so it's 2 circuits in parallel that aren't mixing at all. So again, a child born with transposition of the great arteries has to be mixing somewhere else. They're not going to survive. And so they have to have either an atrial level communication or a duct where some evidence of mixing is occurring. And we need to do an operation that's going to actually remove this parallel circuitry. And that operation is known as the switch procedure. About 50% of these kids have an associated ventricular septal defect, and all of these kids require surgical correction. So the arterial switch procedure is actually to take the great vessels and switch them so that they're connected to the appropriate valves. And if you think this through now, what's happening is we're taking the morphologic pulmonary valve and we're making it into the aortic valve. And we're taking the morphologic aortic valve and making it into the pulmonary valve. But the only way this operation works is if you actually transfer the coronary arteries then to the correct systemic outflow tract. And that's usually the most technically challenging component of the operation, because not an insignificant number of these kids are not only born with transposition of their great vessels, but their coronary anatomy has several anomalies. And so that switch component of these arteries can be quite challenging. And these arteries usually measure about 1 millimeter to 1.5 millimeters in kids that are neonates when we're doing the repair. So this is Dr. Jatin. Dr. Jatin was the one that described the arterial switch procedure. And you can see it wasn't that long ago that he published the sentinel paper on the switch operation. He had started to do the switch procedure in 1987. And he had 116 patients that had undergone the repair, and 43 of these patients had died. So he had a 37% mortality, and he made it very clear that he only did this operation on kids that had normal coronary arteries as diagnosed by echocardiography preoperatively. And depending upon which series you read, upwards of 10 to 15% of kids with transposition don't have routine coronaries. And so obviously the mortality figures were higher. Current mortality rates are about 3 to 4%. And in our program over the last 5 years, our mortality rates for the switch has been 1.9%. And so again, it's pretty amazing to see through all of the technological advancements, diagnostic advancements, and advancement in terms of how we run our cardiopulmonary bypass circuitry, that the mortality rates for both of these lesions has dropped dramatically. So we've made great strides in the US and Canada and in developed nations within our European colleagues in terms of being able to do these operations and reduce these mortality statistics, but the disparity worldwide is quite amazing. So 52,739,240, and what's that number? It's twice the population of Canada, it's 1/6 the population of the US, and it's the entire population of California and Texas combined, to give you some perspective. And that's the population of the world multiplied by the incidence of congenital heart disease, which is somewhere around 1%. And it's impressive to know that 93% of the children in the world with congenital heart disease have no access to care. So they don't have operative interventions, they don't have diagnostic tools to ensure that correct diagnoses are made. And that's more than 2 times the world population infected by HIV. And so congenital heart disease is the #1 birth defect in the world, and it's the least adequately treated birth defect in the world. And it's not even close in terms of what the statistics show. So what can we do about this? And our program has been very involved with humanitarian efforts, not only within San Antonio, but traveling abroad. And it's a very, very small dent that we can place within this disparity, but I think it's a valuable dent that we need to try to make larger. So our team here at the Health Sciences Center has made 4 trips to Jerusalem and actually 1 trip to the Gaza Strip over the past 5 years. And the last trip was in 2013. We had 10 team members from the Health Sciences Center and UHS, and we spent 9 days over there. And we took a team that consisted of surgical expertise, ICU attendings, a pediatric cardiologist, a perfusionist, a mid-level provider, and 4 ICU nurses, and we did 14 cases. Over the course of the 5 trips that we've done 72 cases. And we keep track of all of our statistics and whatnot. And usually about 2/3 of the cases that we perform when we go overseas are on the bypass machine, and so we have to construct our own bypass circuit when we get there. So the challenges that we face when we go over are things like obtaining adequate governmental permission, discussing issues with the hospital administration, because this is a hospital that doesn't normally do pediatric heart surgery, getting through customs, getting through all of the security, arranging the local travel, planning with a local pediatric cardiologist exactly what cases we're going to perform and how to sequence those cases, and then obviously the patient availability, travel, and follow-up. So I thought I'd share with you a couple pictures just to give you, again, some perspective. So this is the surgical tray and the headlight that we had the first time I went, which was back in 2008. And I quickly realized that we needed to bring a lot of our own instrumentation and other tools to do these operations safely. So this is the operating room that we operated in. It's an operating room that doesn't have any climate control. And in congenital heart surgery, we're very particular about cooling the room and cooling these patients when we put them on bypass. And the average temperature in these rooms when we were there for the week, and has always been the case, was about 74 degrees. And so that's always a big problem. Sterilization is a big challenge. So we drape with these towels, and they're sterilized in between cases, but they'll come back with blood stains and other stains, and you just have to have hope, and you pray that they're actually sterilized appropriately. This was our ICU. We had a 4-bed ICU that we converted into a pediatric ICU, and we've done that every time we've gone over. The echo machines and equipment are pretty antiquated. The ventilators that we use are extremely antiquated over there, but we end up getting good results, and it's a pretty exciting experience. And I will tell you, more so than just going over there and helping these kids, there's nothing on the yearly basis that we try to do this on that is a bigger morale booster for our team. It really gives all of us perspective in terms of the day-to-day challenges we face here and all the things that kind of get us excited and anxious and worried and nervous. I don't think we should tend to shy away from the desire towards perfection when we're at home. But I think sometimes going abroad and being blessed to do these things gives you a different understanding about what it is we have to be thankful for in terms of the environments and the tools and the types of people that make up our team that we get to work with here locally. We've tried to do this also in San Antonio. So Heart Gift San Antonio is a program that John Calhoun and Tom May started right when I arrived in San Antonio. So it's a community-wide philanthropic group. We bring patients from around the world that live in countries that don't have access to congenital heart surgical care to come into San Antonio. So a child is recognized through various humanitarian organizations. We have a formalized medical decision-making committee that looks at all of the cases. We decide which cases we're going to accept. The child comes with one family member, spends about 6 weeks in San Antonio. The first week is seeing pediatricians and dentists and all people that have bought into this program and getting the child prepared for surgery. The child has the surgical correction and then spends about 4 weeks in San Antonio under our watchful eyes to ensure that recovery is having appropriately, that the echocardiograms look good, the incision's healing well. They get to spend some time at the zoo, they go to SeaWorld, they have some fun in San Antonio, and then they head back home. So we've done a total of 38 patients over the past 6 years from 12 countries. During our first year at UHS here in 2014, we had 7 children we operated on, and we've got funding and budgetary plans for 8 children in 2015. And so I wanted to share with you just a little bit about this disparity that's quite alarming and things that we've done as a large team and a large program to try to narrow that a little bit. So we spent the better part of the talk so far talking about 2 lesions and all of the changes in terms of the outcomes and what we're also trying to do in terms of some outreach and third world work. But who are we as a team? And about a year and a half after I arrived, I sat down with Dr. Calhoun and I said, we need to have some strategic thoughts about where we want to be and what we want to do and how we define ourselves. And so who are we? What are our goals? Who do we serve? How do we create a better team? How do we thoughtfully and unemotionally and transparently measure our metrics? How are we comparing with other programs? And what can we do to devise some process improvement strategies? How do we continue to get better? And this was a project that was really important to me as I made the transition about a year and a half after I arrived in terms of what are we going to do next? So we came up with some programmatic goals at that time. We want to treat not only the neonates and the infants, but we want to be a family-centered program. Many of you have children, some of you may have grandchildren, some of you may be aunts or uncles, and that concept of your child being born is something that really is a magical thing that oftentimes people always say is the most happy time of their life. And you have the baby showers and you get the nursery ready and everything is all exciting. But if you have a child that's born with severe congenital heart disease and you have to deal with that reality after your child's born, your world really collapses. It's not uncommon you're going to be in the hospital for 4 to 6 weeks. It's not uncommon in the United States that you're going to be transported to a quaternary care facility that may be hours away from your home. And so all of these magical things that you've prepared for 9 months for have to hit pause, and it's a pretty harsh pause that it has to hit. And so we recognize that being a family-centered program was going to be very valuable. We wanted to make sure that we engaged with our academic and hospital partners to create a structure driven towards excellence. And we recognized very much so that our relationships with our providers in South and West Texas was really the way that we would be able to build our program. So we focused on actually defining what our team was going to be, and that our team had to be a true team that rounded together, talked together, had conferences together, and really structured a true academic program. And again, this was a process that we started in 2009. And so currently we have 8 cardiologists in our group, 2 surgeons. We went to our anesthesia colleagues and we told them that we'd like to create a structured program where only 3 or 4 of them did the heart cases. So it would be a structured PD cardiac anesthesia team, and they really bought into that. We also recognized we needed to have cardiac-focused nursing teams, transport services, but always to come back to the patients and the families. And we had this vision of creating a dedicated pediatric cardiac ICU, and I'll tell you more about that a little later in the talk. It took several years for that to come to fruition. We recognized that we needed to have a dedicated single ventricle program, that these were the sickest kids that we took care of, and we needed to actually recognize that how we cared for them, not only in the operating room, but in between operations, had to be unique from all the other kids we cared for. And we created the weekly structured clinical conferences that we have and the monthly quality improvement conferences that we have. And I think likely some of these things are resonating with things your program has done in terms of moving towards excellence and maintaining that excellence. So we know as part of the Health Sciences Center that we serve 39 counties in South and West Texas, 13 of which are the poorest in the U.S. About 2,000 children are born in South Texas with congenital heart disease per year, and we perform about 300 to 400 surgical and catheter-based heart surgical procedures per year. So how do we compare? Well, if you look at congenital heart surgeon programs in the country and you look at statistics, they're usually looking at the breadth of the team and care, and the primary outcomes metric is mortality. But we figured that we needed to go beyond that. It wasn't just what our survival rates are, but how are we in terms of being good stewards and partners to our academic and hospital affiliates, meaning were we providing value? Were we providing value to our families, and were we providing value to the Health Sciences Center and to our hospital partners? And so we embarked upon a research endeavor that employed the use of the Texas Inpatient Public Use Data File. It's a data file that has public access. Anybody can get into that public data file, and it's something that's mandated by the Texas State Department of Health. So initially, we wanted to look at our mortality statistics, and we went back to 2005, and we looked at our mortality statistics every year, and we compared it to a benchmark paper that came out in the January edition of the Journal of Pediatrics in 2013. And that article was really a sentinel paper on congenital heart surgical programs because it looked at 68 pediatric heart surgical programs around the country over a 4-year period of time, over 69,000 operations, and it showed that the overall mortality statistics for congenital heart programs was about 4.1%. And so we were really excited that we were well below those national standards, and in fact, over the course of the last 5 years, we've consistently been under 2%. So that was a good start, but what did that mean in terms of our competition here in Texas and regionally? So you can look at this inpatient public use data file, and using administrative codes, you can look and harvest data for almost any type of operation that's performed in the state. And so we looked at 3 complex cyanotic lesions. We looked at tetralogy of flow, transposition of the great vessels, and total anomalous pulmonary venous return. And the reason we keyed on those 3 operative procedures were that they all require operative intervention within the first 6 months of life. And so we thought that would be a good cohort of patients to study. We harvested the data from 2007 through 2012. The data usually comes out in the data file about a year afterwards, and so the 2013/14 data is just becoming public knowledge. And we were able to query and understand that 11 hospitals statewide performed congenital heart surgical procedures, which actually surprised me. I thought it was less than that. We harvested the data for every single program in the state for those 3 lesions during that period of time. And the data that we harvested were not only the mortality or survival statistics, but the lengths of stay for babies that had those lesions and had an operation in those hospitals, and the hospital charges. And we thought we would create a metric of value, meaning programs that had higher survival rates but lower lengths of stay and lower overall hospital charges would be deemed the highest value programs. And I can tell you with all due honesty and transparency, we had no idea where we would rank. But we thought that this was an important endeavor, not only for us to understand where we were, but we thought it would be a good academic exercise for our entire community, because with where we're headed in terms of our fiscal limitations and challenges in healthcare, this would be a good metric, and it may be a good platform by which other large, high valued programs could look to in other subspecialties. So just for example, the 2012 data submission for this data file had somewhere between 550 hospitals, depending upon which quarter, and it had millions of records in terms of its initial database and millions of records for charges. So this is a pretty complete database. So this graph depicts the 11 programs, and this is again the survival rate for those 3 operations over those 5 years amongst these 11 hospitals in the state. And so the average survival was 97%, which is great. So the state of Texas is doing pretty well. 4.1% is the national average. In Texas, it's 3% in terms of mortality. And at the UT Health Sciences Center, we actually had the highest survival rate, which was over 99%. And so we got pretty excited. We said, well, wonder what our lengths of stay are and our charges are, because if they're really high, then the argument's going to be that we paid a lot, we kept them in the hospital for a long time to help them survive. So the average length of stay was just over 17 days for all of these programs, and we were, again, very excited that we had the lowest length of stay in the state. So again, over 5 years, these 3 lesions, we were at 12.72 days. And then hospital charges, the average charge for a patient having one of these 3 operations was $250,000. And we weren't quite the best, but we were close. We were at $166,740, and Cook Children's in Fort Worth was a bit better. So we had data on mortality, we had data on overall lengths of stay, and we had data on hospital charges. And so I went to the business health program at UTSA, and I met with a guy named Dana Forgione, who's one of the smartest guys I've ever met. And I told him that this is what we've done, this is how I'm thinking in terms of what value should be as not only what we're providing to patients and families, but to the hospital, to the community, to the state. How do I somehow describe that in terms of a way that people would better understand it? So he came up with this value index. And so the value index is an index that has on this axis unadjusted total charges per case by hospital, and this being unadjusted survival rates by hospital. So the higher you are on this graph, the better your survival rates are. And the further left you are on this graph, the lower your charges are. So the best quadrant to be would be this quadrant: higher survival, lower charges, and we're program number 3. And so these were the other 2 programs. This is Texas Children's Hospital, and this is Cook Children's Hospital in Fort Worth. And so we presented this at the Society of Thoracic Surgeons meeting in 2013. It won the top congenital poster, and we had this work published in the Annals of Thoracic Surgery. And so it's been an exciting project that took a long time to come to fruition, but I think was really important for us to move forward. So the big change occurred for us in the fall of 2013 and into 2014, moving to UHS. And so this, for me, was another inflection point in our program. Over the course of 2009 to 2014, we had built all the things that I just shared with you in the last few slides, but now we were coming to a new home.
Adil, just to clarify then, all that data was CHOSA?
All of it was CHOSA.
Okay.
Yep, all of it was CHOSA. And so we're coming to a new home. What do we do now? And it's a great opportunity to take a step back, hit pause, and redefine ourselves and figure out, are we happy with where we're at? What have we accomplished? What have we learned by what we've accomplished? And now what's next? And so the first and foremost thing before I get into some of these other things was maintaining our team. And what was exciting was that every cardiologist, every surgeon, the anesthesiologist obviously were part of TAPVC, every intensivist all moved over to UHS with us. And all of us had a lot of different opportunities to not do that together, but we collectively decided over the course of several meetings to at least come over together and see how things worked out. And the other biggest thing was that we were able to keep a lot of our ancillary support. So a lot of the key nurses, a lot of the key mid-level providers, a lot of the key ancillary support folks, RTs, PTs, they all came over as well. And so no doubt our home was different, but the faces were familiar and our team stayed intact, which was very important. So we sat down about a year ago. I sat down with Dr. Calhoun and Dr. Nish, who's our PD cardiology chief, and I said, give me a couple hours, let's talk about where we're headed, and let's try to answer some of these questions. What's our vision? Why do we believe in our vision? How do we achieve our vision? Is our vision capable of transcending beyond our program? We're starting at a new place. So the most important thing that I felt we should focus upon in this move was to take advantage of the fact that if you move, you can create the environment you want to move into. And so we wanted to create a dedicated pediatric congenital cardiac unit that was separate from the pediatric ICU, that was focused completely and solely upon taking care of kids with congenital heart disease. And it wasn't a surgical ICU. It was where all the kids that got CAF'd went. It was where all the kids that had sedated echoes went. It was where all the kids that had end-stage cardiomyopathy that had no further treatment options went to get their palliative care initiated. It was the place you went if you were a child, an infant, or even a young adult with congenital heart disease. It's a variable acuity unit, so once you're in a room, you're going to stay in that room, and your status is going to change. So it's not that you're going to go from an ICU area to a telemetry area to a rehab area. You actually stay in the one room. And it's dedicated to all patients with congenital heart disease. It's family focused. And so when we moved over to UHS, one of the most important things that we talked about with our UHS leadership was that we wanted to create an environment that wasn't only for our patients, but it was an environment for our families. And so the 9th floor of the tower, actually, we're going to undergo a large renovation project in the spring where the second side of that 9th floor is actually going to be committed to our families. So in that side, there's going to be 6 rooms that are essentially going to be hotel rooms that are going to have the ability for families to be there while their children are in the hospital for 2, 3, 4 weeks at a time. There's going to be kitchen facilities for them, laundry facilities for them, playrooms for siblings, and a dedicated computer and IT center that I'll tell you a little bit about in a while. We're also going to have rooms that are known as rooming in rooms. So if you have a neonate that has gone through the first stage of a hypoplastic left heart syndrome operation and they've been in the hospital for 4 or 5 weeks and you're getting ready to go home, but that leap to go home now is a scary one, especially if you live hours away. So you essentially bring them over to the other side of the floor. You have a little apartment type environment. You're there with your child. And over the course of 3 or 4 days, 5 days, you gain some confidence, but there's physicians and nurses that are literally on the same floor should you have questions or needs arise. And so we're really created a family-focused unit up there on the 9th floor. The other thing that I thought was really important when we moved over was to take advantage of the fact that now having some more visibility on this campus, we needed to get an endowed chair. And so we worked with the William Randolph Hearst Foundation and a gentleman that some of you may know who's got a lot of San Antonio roots, George Irish, who works for the Hearst Foundation. And he was kind enough to give us some time, so went up to New York and visited with him, had him come down for a visit, and described to him this vision, described to him what we were trying to do. And the Hearst Foundation donated $750,000 to our program, and the school actually helped match that, so we're nearing $1 million endowment for the heart program that's going to be focused on the single ventricle program and this new family-focused unit. And so that's been a real exciting thing. Part of that endowment is to have a yearly visiting professorship, the first of which occurred this fall. And so we had Dr. Carl Backer, who's the chief of CT surgery at the Children's Hospital Chicago, come down, and we were pretty mindful about choosing him because that children's hospital is the first children's hospital in America that has a variable acuity dedicated pediatric cardiac ICU. And so we had him come down and spend 2 or 3 days with us, walk through the blueprints of our program. He met with Mr. Hernandez and the UHS leadership, met with some UT leadership, and it was really a nice fuel source to get a lot of the things that we had been talking about to our leadership and have him describe how much of a transformational change it had made to their program in Chicago. So this is just a small sample set of papers that have been written in the very recent past regarding dedicated cardiac ICUs for the congenital heart disease population. And they basically all will give you 4 major points to take home. 1, that outcomes are better, that mortality statistics are lower for programs that have these types of programs. 2, that survey scores in terms of families, nurses, ancillary support are all higher in these units because it's a committed, dedicated unit to that disease entity, and people who are very passionate about wanting to work in that environment find a lot of satisfaction there, and the families really feel like you're committing that component of the hospital to the disease entity that their child had. 3, errors go down. Medication errors go down, surgical infection site errors go down, line infection site errors go down, and so overall, errors go down in dedicated units that are committed to a certain patient population. And then finally, actually hospital costs go down. So overall charges per patient goes down in those types of dedicated environments because of the focused care that they receive. And so all of these things I think are extremely valuable and powerful data-driven tools to advocate for this type of unit. So this is how I think one should structure a dedicated unit in regards to a specific highly subspecialized disease entity. It should be an amalgamation of patient, family, physician, and staff. So what have we done in terms of patient? So the unit opened in April of this year when the tower opened up. And in terms of patient-focused issues, we've established the dedicated unit. We've created an organizational nursing patient care coordinator structure. So for each day and night shift, there's actually what's known as a PCC, that's UHS speak. It's a vision that's supported by RT, pharmacy, and social work. So we have dedicated RT, dedicated pharmacy, and a dedicated social work staff for the unit. And it's debriefing sessions with families before and after conception of the unit. So we actually had 4 families who had required an operation before the unit opened up at UHS and then after the unit opened up in terms of their staged operations. And we actually, even though it was only an N of 4, went through a very thorough debriefing session that was in terms of them answering a questionnaire and then having individual interviews with them as to what they saw the difference to be. And we used all of that material that we gathered to, again, go back to our administrative leadership to explain to them the impact that the unit had on these families, which was actually a really important process for us to go through. What we're anticipating is to formalize the commitment to all neonatal infants and pediatric patients with heart disease. So we're working with our neonatal colleagues where if a child has a fetal diagnosis of hypoplastic left heart syndrome, as soon as they're born, they come to our unit. We're working with our medical colleagues so that if a child who has a previously repaired heart for congenital heart disease comes in with a bad bout of the flu or a bad other medical issue, that if they feel that their care would be better served in our unit, that we'd have a bed available for them. And so we're working on formalizing this concept more hospital-wide. What about the family? As I said, we've gone through some qualitative improvement scoring systems and discussions and debriefing with these families in terms of their experience and satisfaction. We just hired a complex care coordinator, so this is a person that meets the family the day that the family's admitted into the unit, and they are their point person of reference throughout the hospitalization. Where do they eat when they're in town? What else do they need in terms of a family? If they're going to be going back to El Paso or Laredo, what do they need in terms of RT, PT, OT at home? Who sets all of those things up? What type of nursing care may they need at home? And so this complex care coordinator position has been really important for us to find. I'm not much into this, but a lot of the folks in our unit have created some links for us in terms of some social media and support groups, which I think have helped families. In progress, we want to create a specific programmatic support group for our families, and we're actually having our first reunion of all the children that have been treated at UHS and their families on Valentine's Day weekend, where we're bringing all the families back who have been here for the past year and have had care here. And we want to work with them to create a programmatic support group. So I've talked to you about improving the physical space in terms of the hotel rooms and the rooming in suites and all the other facilities. And then the first project that I want to work on with the Hearst endowment, and I've talked to the endowment about it, and I've had some discussions with Apple about it, is to actually create computerized interactive rooms within the ICU. So each room in the ICU will have a computer station, and on that computer station we're going to load bilingual educational modules for all of the congenital heart defects. So if we go in and we talk to a family about lesion X, and we explain to them what the issues are with that lesion, why the child needs an operation, we can do that at the same time by linking them through a computerized educational module that they can go through while we're talking to them. And then these modules actually have questions at the end, and we can let them then go through the modules on their own and then come back and see how they scored on the modules, so that we really feel like they have a better understanding of what their child has, and perhaps it creates a platform for them to better understand the ability to ask the right questions. We'll load them also with all the social media things, so if they've got all of their family back down in the valley, they can FaceTime with them, they can Facebook with them, they can do all of those things, and they may have a family member down there that couldn't come up, that really wants to be part of the family discussion for consent, and we can FaceTime with them and all do it together in their room. And so we're going to be setting up these individual computer stations within each of those ICU rooms for those families. And I think it's going to be revolutionary in terms of how we better obtain true informed consent and have the families really feel as if they understand the complexity of the challenges that their infant or child is going through. What about for the physician? So obviously we had to go to our pediatric and critical care colleagues because we were dividing their division. They're going to now have to cover a cardiac unit and cover ICU over in the Sky Tower. And overcoming some of that fragmentation has been a challenge, but I give them a lot of credit in terms of buying into it. And really having an emerging commitment to serve as the primary physicians for all these patients in the PCCU. We have a true leadership structure, so the chief of PD heart surgery, the chief of PD cardiology, the chief of pediatric cardiac critical care, the nursing director for the unit, and the inpatient nursing director. We get together for an hour every Thursday morning. And we have an agenda, and we talk through all of the acute issues for the past week, the near misses in the ICU, the challenges in terms of throughput, but we also talk about bigger, larger picture things, strategic things that we want to do as a team, things we want to do to continue this process of improvement, and it's a true amalgamation of physicians, nurses, administration, Health Sciences Center, UHS folks all getting together for an hour a week that's committed to talk through all of the issues that our program's facing. In progress, we're orienting several new PAs and NPs that are going to be working in the unit, And again, we want to think about how can we expand the space now for perhaps outpatient services. So that, is there a way, whether it be on the 9th floor or maybe up on the 11th floor, all of our outpatient clinics could be held, our outpatient echoes could be held, so that the families really would come to just one place rather than having to navigate the system. For the staff, I think it's been exciting to see a growth of a dedicated nursing pool, involvement of the nurses in our program. So they lead our rounds every day. Our whole team rounds together every morning, and it's actually the nurse that leads a round. They give the update as to the post-op day, the acute issues, the events over the last 24 hours, and they're asked and they're focused on also giving us a sentence about how the family's doing. Mom's going to be going back because she has to go back to work, but dad's staying here, the family's having issues with this, and that complex care coordinator rounds with us every day as well, so that those issues that come up on rounds that are family specific, she can start working on. We want to create a standardized educational curriculum for our staff. We're still a little bit behind in having a dedicated nutritional and dietary team for our unit. We want to create the ability to have a resource nurse every shift, so that there's a nurse that isn't taking care of any patients, but they're just floating around helping the other nurses in the unit taking care of those patients. And again, I think we have to amalgamate the entities that belong to UT versus UHS. We have to integrate our human capital. And we want to look for and towards hiring a formal cardiac educator, not just in terms of helping our nurses, but our mid-level providers, our ancillary support, and even our families. So what have we accomplished in the year that, well, I guess since April that we've opened, we've had 242 admissions. Our average length of stay has been 10. We've only transferred to another unit prior to discharge in 17 patients, and overall mortality for the unit for all admissions has been 1.5%. So I told you a little bit about the Hearst Foundation. We want to establish a visiting professorship yearly, create these educational bilingual modules that we can implement into each room. And then the next step of the endowment is to create a statistical database that allows for the management, analysis, and scholarly reporting of outcomes, especially on those single ventricle kids. Programs have done a good job since they've improved on the Norwood to report that their mortality statistics for that first operation are down, and that overall more kids are getting through all three, but I think we need to advance that. We need to better understand how they're doing in terms of their developmental scores. Are they making it to kindergarten? How are they amalgamating themselves into society in terms of other kids? We've talked a little bit about these things already, but these are really the next steps that we have in line for the Hearst Endowment. So the single ventricle program that'll be part of the Hearst Endowment, we've had 11 single ventricle kids our first year here. 9 have been discharged to home, 2 are currently in the hospital, so actually our survival rate has been 88.9%, or a mortality rate that's just over 11%. We have a dedicated weekly single ventricle clinic, so once a child has that first operation, before they get the second operation, they actually come back to a weekly clinic where they're weighed, their SATs are checked, and all of these things that we want to input into a database for longitudinal outcomes analysis for these kids, we're starting to enter when they come into the single ventricle clinic. And I think understanding their neurocognitive development and other associated developmental milestones is going to be really valuable to see how these kids track down the line. So this is our team. It's a big team, and we're really very fortunate that a large number of these folks actually weren't part of the UHS system but agreed to come over with us when we moved last year. So what's our vision? We need to be excellent, not only in terms of just normal outcomes metrics like mortality, but also be committed and have a focused family-centered approach. Do we believe in our mission, and why? Because we think it's the best way to achieve excellence, and we know that it's data-driven. How do we achieve our vision? We have to develop trust and relationships. We have to make sure that we understand that bringing together our partners at UHS and the Health Sciences Center on all levels, not just physician, but nursing, ancillary support, is the way to create these trusting relationships. And actually, we think we can transcend this beyond our program. One of the largest challenges we face in congenital heart care in San Antonio, but I think in the care of pediatric patients and other patients, is that it's an extremely fragmented way of delivering care. And I think creating these types of dedicated, very structured, patient and family-oriented programs may create some excitement that'll transcend not only our program, but other programs around the region. And I think by doing something that people find value within, you can hopefully bring people together. And so I do think that this is something that could be on the forefront of transcending beyond our program. So what's every beat? Well, I think every beat in a congenital heart program has to deal with the beating heart of a patient, the family, the physicians, and the staff. So For the patients, we've got a single dedicated setting for care, a clinical attention to detail. For family, a comfortable environment outside of just the patient care area, a communication structure, an educational structure that employs kind of some of the latest IT technology that we have, and supportive entities. We almost want to be providing them a concierge service. It's silly to say that they're in a hotel environment, but if we can use some of those philosophies that the hotel industry has used to really create an environment of satisfaction for people that come visit them, we should be no different for these families that unfortunately are having to go through a very unfair time in their life where their child's in the hospital for a long period of time. For the physicians, a multidisciplinary team, we want to have defined roles, but we want to avoid silos. So the cardiologist should be autonomous in the decision-making algorithm of what they're doing, and the anesthesiologist should have that defined role, but we need to be a program. We can't have silos that are working together. And then staff, the leadership structure I talked about, the dedicated responsibilities, and the amalgamation of skills and expertise. So we're always a work in progress. We're very blessed and excited to have the team that we have. And we look to programs like the transplant program that I think does a lot of these things really well. And it's actually been a great opportunity to come spend some time and share with you what we do. And it may be a platform for our programs like ourselves to work together on some of these common themes. So thanks for your time.
Adil, I assume from a funding standpoint, most of these patients are Texas Medicaid CHIP kids, which, unlike many of the third-party insurers, don't have centers of excellence or use the data you presented in regards to picking programs to where is there, I mean, these are very expensive to the taxpayers, I guess. Where does that stand? Or is there anything in that realm?
So it's a great question. I'll answer with two or three things. One, about 77, 76, 78%, depending upon what quarter you look at, are the Texas Medicaid, so vast majority. Insurance carriers for children like Superior, like Optimum, like Children First, they do have centers of excellence. I've become a little bit challenged by what it really means because we've gone through the application process of becoming center of excellence for all these different providers. I do think that it's valuable to have that feather in your cap, but the impact that those entities have in terms of ensuring that hospitals or referring physicians refer to those centers, I think is a bit of an ill-defined issue. Now, there's legislation right now that is looking at trying to create a more streamlined way that neonates are cared for in the state of Texas. And there is a lot of talk within NICUs to be more structured in terms of having regional centers that care for certain disease entities. And I think that's going to be very important to follow. Because in the end, if there's a decision made at that level to broach that theme, then I think this data really matters. And I think that it's important to continue to have a focus on achieving this type of data and this outcome. Because I think once the structure is created for that to happen, and I think eventually it will happen, then it's going to be purely a data-driven thing in terms of where we decide we want to create these tertiary carers, tertiary neonatology centers of excellence for these types of very highly subspecialized diseases.
Thank you so much for the talk. I actually always love hearing about heart surgery, congenital heart surgery, so I'm glad we actually hear King of Hearts is still one of my favorite books. But I was curious about this Texas Inpatient Public Data Use File. Is this a sample database, or is this, how is the data collected? Is it all hospitals in Texas? Is it mandatory reporting? Is it all payers?
So like any of you, and maybe some of you are database research folks, and so there's some good and some bad. The good about the database is it's mandated.
Okay.
It's not, what was the word you used, a sample set?
Like
No,
the
it's
nationwide inpatient
every
sample.
single discharge in the state is in the database. The bad is that it's an administrative database. So you're relying on coding, and there's coding errors. It's bad because there's no state-driven oversight So nobody is going around to these programs and ensuring that what they're entering into the database is accurate. But I think if you're looking at outcomes metrics like length of stay or charges or mortality, there isn't really much room that coding can screw that up other than not actually capturing all the patients. So there's no doubt that there's limitations, but I think for what we wanted to accomplish, I felt pretty comfortable about being at a good source.
And is that mortality in hospital mortality, or are they referencing any
So
follow-up?
it's either 30-day mortality or in-hospital mortality.
Okay.
So for these databases, like for example, if we discharge a patient before 30 days after their operation, we actually have to formally contact the family,
Okay.
and we have to enter what their status is at the 30-day mark. Now, you could have a child that is in the hospital for 120 days and at the end passes because of, unfortunately, let's say a line infection or an aspiration issue, and that's a surgical mortality.
Thank you very much.
Yeah.
I just want to congratulate you on a variety of unbelievable feats. First of all, it's for the tremendous, outcome that you're having. You're basically, the best in Texas, and certainly, above the national average, which is a real shining star for our community. The second is what you've been able to do in an extreme challenge, which is essentially moving houses, and to maintain your team, and actually not only maintain but to enhance kind of a vision and the pulse of what you want to do. And I think your vision about really having comprehensive care of the patient and the family in this environment where everybody knows their roles, but also are not working in silos, is going to be really the example of what we all are doing in this hospital. And I just think that the future is bright. But at the end of the day, it's required a tremendous leader, and you've been that leader. And I just want to congratulate you for your efforts, but also the tremendous outcomes that you're having.
Oh, thanks.
Something we ought to have.
Well, Dr. Calhoun's a great mentor. You go around, I just came back from the Society of Thoracic Surgeons Conference. It's one of our larger conferences, and like your group is very similar to this, and I'm an outsider, but I feel pretty confident in this analysis. It's rare that folks at my stage in my career or other mid-level faculty have, chiefs that care, that really are committed, that historically have strong presence within the community. Transplant's one of them, CT surgery is another one. We've got such an advantage because we have that leadership historically and that mentorship, and I've just been a big beneficiary of that, and the team. A lot of people sacrificed a lot of things to want to stay together as a team, and it's been exciting to see that happen, and that commitment's been very rewarding.
So I think, one of the challenges that I think we have at University Hospital, with the changes that have occurred, is really, to make certain that the public at large and, referring physicians and neonatologists really understand jewel, that exists, within University Hospital on the second floor under your leadership. So anything I can do to kind of enhance that message, and also to make certain that we're branding and communicating that throughout the state. I'll bet you some people don't understand that we actually have the best outcomes in Texas, and we need to continue pushing that, because that is actually, at the end of the day, going to be our trump card, which is outcomes.
Right.
And it's hard to beat these outcomes.
Thank you very much.
Thank you, appreciate it.
Is that inpatient report today?